Thank you for that introduction, and thank you for the opportunity to present on a topic which I think many of you are involved in or have been involved with, and that's about North-South collaborations in clinical pharmacology research. And I have no disclosures other than saying that this is a presentation given by me, so from a northerner perspective. And I want to start with the terminology. So we are talking about global north and global south. This is a UN trade classification that came up as a kind of an alternative for the more valuing classifications like developing world and developed world or third world. And it kind of divides or groups countries based on their socio-economic and their political status. And the reason I give this presentation here is because most of the funding, maybe all of the funding of the research that's being presented today comes from the global north, whereas the burden of disease, of course, not just for HIV, but also for the other viral infections, is concentrated in the global south. So we have to collaborate to make the most impact as possible. And I want to start with a bit of history. Specifically, I want to talk about the 4 phases of global health, as they have been described. And then we start with Global Health 1.0, which started somewhere in the 19th century until the mid-20th century. And then terminology was colonial medicine, and later on it became tropical medicine. And it was really about keeping northerners alive in the tropics, or protecting colonial workers to make sure that they did not become sick and they would not affect ongoing economics. An example is the US invasion of Cuba in 1898, where there was an invasion of the US in Cuba to eliminate yellow fever. And it was not not to help the people from Cuba, but it was to prevent yellow fever for coming to the cities of the US, for example, New Orleans, due to increasing global trade. And they were very effective. In 1 year, yellow fever was eliminated, but it was through a very strict military regime without the consent of the people from Cuba. Later on, we moved towards Global Health 2.0, which started somewhere in the mid-20th century, and it was still named like tropical medicine, and more and more starting to move towards international medicine. In other words, Global Health 2.0 is clever people in rich countries doing something to help people in poor countries. An example here is a classical tropical doctor, a French doctor, performing a lumbar puncture on an African child in Cameroon in 1933 as part of the sleeping sickness campaign. And while these efforts have been usually successful, it was not a very sustainable way of helping people because there was no attention for capacity building. Another example here in West Africa is one of the smallpox campaigns and measles campaigns that have been hugely successful, but these have been all dominated by the global north, funded as well as led with very minimal impact of a very minimal influence of people from the global south. Then we move towards Global Health 3.0, which started somewhere in the mid-80s until recently, maybe still even today. And then with the terminology changed to global health. And this is really research from rich countries, leading researchers from rich countries, leading research programs in poor countries. And this was really, HIV was a real game changer here. And the main reason is that HIV at some point was not just an issue of the global south, but also became an issue of the global north. And there were many demonstrations, campaigns all across the global north as well as the global south, which were very successful in getting more funding and getting more research done into the field of HIV. At first, this research was mainly done in the global north. And the global south could, with quite some delays, also benefit from the results from that research. But more and more research was taking place in the global south, but still often led by researchers from the global north. And nowadays we are increasingly moving towards Global Health 4.0, which is still named Global Health, but it's more and more focused on decolonizing global health, so changing the former kind of colonial influences that are still present here and make sure that it's a real collaborative effort. In other words, this is research and other activities being led by researchers from low and middle income countries, or the Global South. And as I said, Global Health 4.0 is really about collaboration and acknowledging each other's strengths and limitations from the Global Southern researchers as well as the Global Northern researchers. And to come together to the best possible research questions, research methodologies, and improve global health. And a great example of Global Health 4.0 is the story of Dr. Victor Kande from the DRC of Congo, who together with the Drugs from Neglected Diseases Initiative from the Global North, as well as Sanofi as a funder from the Global North, developed a new tablet, the I always have to check, fexinidazole, for sleeping sickness. And it is really all the research that has been done around this drug was being done locally in the DRC and co-led by many healthcare workers as well as researchers from Congo. And nowadays the drug has been approved and is readily available in the high burden countries. So we are getting there. But how does it work for us? So are we at Global Health 4.0 yet? We as clinical pharmacology researchers in antivirals. And I think we have to ask ourselves the questions. So who controls the funding? Who controls the data? Who designs the studies? And also who gets the scientific recognition for the work that's being done? And I thought, that's worth investigating. We are researchers. So I did a small study within my own network to kind of see where my international collaborations are when it comes to Global Health 4.0. I sent out a short questionnaire, about 6 questions to 23 colleagues with representation across geographical settings, so Global North, Global South, as well as research career stage, early career versus experienced researchers. As you can see here, sorry for the many pie charts that I will show you, but as you can see here, there are 20 responses of 23 people who I had approached, which already kind of shows that my colleagues are quite engaged when it comes to this topic. And there is a nice representation from all the different groups. The first question was, who usually decides the research question in your international collaborations? And shockingly, but maybe not surprisingly, 65% said it's a partner from the Global North who decides the research question within the consortium. And 25% said it's a joint decision making, which is a small number. And interestingly, when you look at the 25%, these are mainly researchers from the Global South, and they are all experienced researchers. And this could kind of indicate that these are researchers that have been involved in many different of these collaborations and already see the shift from 3.0 to 4.0, whereas the young researchers or the early career researchers, they just stepped in and they see that we are not yet there. And the research question, as we all know, is extremely important in well, what is going to be done and what it's, and it should really cover, it should really be relevant for the clinical setting. So the question is, are we asking the right research questions? And I just put on some ideas when it comes to clinical pharmacology research, and I start with medication. So, of course, many medications are being studied while they not become available locally. Second, the dosing. From a PK perspective, we tend to make dosing quite complex sometimes, which may not always be applicable in the Global South, for example. And looking at my own research, I once did a complex PBPK modeling exercise on looking at novel dosages, novel dosages for lamivudine and emtricitabine in children with reduced renal function. And it was an academically very interesting study to do, but in the end, it resulted in dosages that were could not be applied. So the impact was minimal. Looking at drug-drug interactions, we could study irrelevant drug-drug interactions, or we could also think of not studying drug-drug interactions that may be relevant for the local setting. For example, looking at traditional medicines and also looking at food-drug interactions of foods that are taken in the high-burden settings. And pharmacokinetics, of course, many genetic panels are being developed based on the population in the global north. It may not always be applicable for the population in other settings in the world. So my next question was more or less breaking down the research within the research consortium. And I looked at which partner typically brings the most input at the different research stages. And not surprisingly, when it comes to study design and methodology, this more or less comes forth out of the research question I asked before, is dominated by the global northern partners. When looking at regulatory and ethical navigation and also participant recruiting and retention, this of course is often being led by the southern partner because that's where the patients are. And then interestingly, when it comes to data analysis and interpretation and also writing and publication of the manuscript, this is where the northern partner comes in again. And this is really where you get the scientific recognition. And talking about recognition, the next question was about who usually receives the most recognition or credit for the research in your collaborations. And it was a tie. So 45% says it's a northern partner and 45% says it's shared fairly. But I think recognition is a very vague and broad term, so we have to break it down a bit. Just some thoughts on how to get recognition. Of course, we all know authorships may be very useful for an academic career or to get scientific recognition. And it's great to see that more and more researchers from the Global South become first authors on main and impactful papers. For senior authors, in my opinion, that's not really the case yet. And we see the number of authors also very much increasing with the et al. Authors to make sure that we can get recognition for as many people, for many people within who have contributed to the study. Then there's the presentations at scientific conferences where you can get some recognition. And the issue here, of course, is that many of the conferences are being held in the Global North and may therefore not be as accessible for everyone from the Global South. And the third one is being part of the international expert groups and also in the international expert groups. In my opinion, these are often dominated by researchers and clinicians from the Global North. And there's another thing when it comes to recognition, but I think is important to touch on, and it's we should be careful with the terminology and also be aware of not doing this. And it's called tokenism, and tokenism is inclusion without real influence, just to appear inclusive. And while it's great to give recognition to important people within the research collaboration, it's also well, it can be kind of a fake recognition, and it doesn't really contribute to capacity building in research, and it's not a sustainable way of gaining recognition. So I asked my colleagues on tokenism, and I was quite shocked that 55% says yes, I've experienced tokenism within my research collaboration. And 10% said yes frequently, and only 5% said no, never. And I think this is something we should really consider and think about. The last question was about power imbalances. So more or less who makes the decisions within the research collaboration. And well, I kind of messed up with this question because I included the orange one, which was my influence depends on the project or partner, which is kind of the easy way out to answer the question. But also, so 45% went for this for this answer, and it also maybe says something about differences between the different collaborations in how well everyone is involved. When it comes to making the decisions, there are still some inequities that I think we should consider. So first, of course, we have the historical and the structural disparities or inequities. That kind of still, so it's the way we do it, and that still continues to be done. With the financial and resource disparities, which of course the global north has a lot more financial and resources to bring into the consortium, and who pays decides is often the case. What we should also consider transferring, for example, when we do PK research and we are working with UPLCs or with LCMSs, we should consider whether we should transfer some of those equipments also to the global south, make sure that it's available there with the appropriate training. These are things to consider. And knowledge and expertise in the global south may not always be as appreciated as much as the knowledge and expertise in the global north, and this is really an issue. And at last, the institutional structures. So for me, for example, trying to build my research career, it's important to be the first author on papers or to be a senior author. And also when I apply for funding, my university asks to get as much funding as possible for my own university. So this really kind of influences the equity in research collaborations. So then the conclusion, are we at Global Health 4.0 yet? I don't think so. But I think we are trying, and we are hopefully getting there in some time. But I don't want to end with a negative kind of vibe around global health or north-south collaborations, because I think they can be extremely impactful. If we, for example, look at the pediatric dolutegravir case, where through many different north-south collaborations, they have been able to develop the pediatric dolutegravir tablets and got it available all across the world in a very short period of time. And it's fun, of course, networking, friendships, and cross-cultural teamwork, and also exploring the world a bit by doing that thing you like most, PK research. Okay, so the way forward, North-South collaborations, in my opinion, are becoming more and more equal and more focused on sustainable capacity building. And also funders like the EDCTP, for example, they really try to focus and promote on more equitable power balances within the funded collaborations. And one of those examples is the support trial, which is a training program funded by the EDCTP for 13 early and mid-career researchers across various countries in sub-Saharan Africa. And the nice thing is that the supervision of the fellows is really shared between the northern and the southern partners, as well as the leadership of the consortium. So I really much look forward to what this will bring us. And I want to end with a call to action. So this presentation is not really about labeling collaborations as good or bad, but it's really meant to spark kind of curiosity and encourage critical reflection on your own collaborations and partnerships. And in future projects, I hope that you can sit back and think about some questions, and the first one is who asked the questions within the consortium, who makes the decisions, and also who gets the credit for what is being done. And with that, I'd like to thank you all and give the word to the moderators.